Hi, good evening everyone, and welcome to Glooko Symposia session, the use of AI, machine learning, and digital therapeutics for behavioural modification. My name is Matt West. I'm one of the partnership managers here at Glooko, and we are all excited to have you join us today for this online evening session at Diabetes Professional Conference 2022. Now, as this is an online symposia, I wanted to cover off some key points. Specifically, today's session is being recorded and will be made available on demand until October 1st by Diabetes UK. Glooko will also be sending out the recorded presentation over our mailing list, so if you are part of our mailing list, you will receive this there as well. Lastly, we will provide you with some contact details at the end of the session should you wish to reach out with any questions, and we encourage you to do so, as our team would be more than happy to support you in answering those. Now, before I hand over to our fantastic speaker for tonight, I just wanted to quickly explain a few things about us as a company and what we do. So first of all, who is Glooko? Glooko is a digital health company that is helping transform how diabetes care is delivered by connecting people with diabetes to their healthcare professionals, helping to enable crucial processes in clinic, such as enabling remote care delivery, clinical research, and improving collaboration between care teams. We have approximately 3 million active patients using the Glooko platform, and that's across 7,500 clinics globally. And as you can see here on screen, that is across many countries, and the product is provided in many different languages too. So, looking closely at the Glooko solution, what does it consist of? So around the edge, we have the various different ways of getting data into the Glooko platform. In the top left, we have the Glooko transmitter. This would typically sit in clinic and allows for uploading a variety of different devices in a convenient way for clinicians. Below that, we have the Glooko smartphone app. This is primarily how patients would interact with the Glooko platform, and allows them to upload a whole range of devices via Bluetooth and NFC, as well as manually input various events. On the right-hand side at the top, we have third-party applications. Many of these can be connected by patients to Glooko and allow for a passive flow of data through to the Glooko platform. Finally, in the bottom right, we have the uploader. Patients and clinicians can use this again to upload data into the Glooko platform, and data from all of these different sources will flow into the reports that you see in the center of the screen there. We have summary reports showing more aggregated data and trends, all the way down to more granular reports focusing on the details for each day. So which devices are compatible? Well, we actually have almost all different types of diabetes devices compatible with the platform. We have blood glucose meters, CGMs, connected insulin pens, pumps. We have a whole host of different brands of each variety. Now, you'll see here that all the data for these comes together again in those reports, standardized reports, regardless of the manufacturer, brand, or model of the device that is being used. Now, this provides clinicians and patients with a massive amount of choice as to the devices that they use. It allows clinicians to make recommendations specific to the requirements of each individual patient, and regardless how those requirements change over time for a single patient or how they change in terms of each individual patient, a clinician can consistently review reports that are standardized, that they can interpret quickly, gain deep insights from, and they can use those to shape how they deliver diabetes care. So now we look at what we provide to clinics and healthcare professionals. Ultimately, the uploading for both clinics and healthcare professionals is going to be done using the Glooko transmitter, as we see here, or the Glooko uploader, which would be installed on a computer. Data would be uploaded from both of these and would be able to be viewed within the reports shown on screen, starting of course with the summary tab and then going into those detailed views that I spoke about before. For individual days, we can see how a patient is handling with specific life events, how they are coping, perhaps adjusting their therapy accordingly. We can also see reports that are specific to different devices, perhaps looking at events that are unique to insulin pumps. And we also have more traditional views, such as the logbook, which I know is a popular view for many healthcare professionals. When looking at what we provide for people with diabetes, as I said, the smartphone app that is available for both iOS and Android is the main interface that patients would use. Here they can upload a variety of devices by Bluetooth and NFC, and they can even manually enter a whole range of different events, as you see here on screen. Patients can also connect third-party applications, as I said previously, and this will create a passive flow of data, meaning that it's incredibly easy to keep healthcare professionals up to date with their progress. So now we move on to the main part of our symposia. So I just wanted to introduce our fantastic speaker that we're going to be listening to today. So our speaker is Dr. Mark Clements. Dr. Clements is Chief Medical Officer at Glooko and is a professor and pediatric endocrinologist. He is also a clinical researcher of the new diabetes treatments and technologies, and having served as a principal investigator or co-investigator in more than 30 clinical studies and patient registries. He has served as chair of the Type 1 Diabetes Exchange Clinic Registry and currently serves as data science co-lead for the Type 1 Diabetes Exchange Quality Improvement Collaborative. So without further ado, I'll pass you over to Dr. Clements.
Thanks, Matt, for that kind introduction. So our objectives today will be to learn how machine learning can first help us identify at-risk individuals in our clinical practices, to help identify optimal moments and approaches for nudging behaviors that drive outcomes, and finally to consider how digital therapeutics can be used to nudge individuals toward health-promoting behaviors in their diabetes self-management. A couple of disclosures I'd like to share. Of course, I'm the Chief Medical Officer at Glooko, and I have in the last few years received research support from both Dexcom and Abbott Diabetes Care for some academic research I have performed. A couple of additional disclaimers. First, I do not consider myself an expert in AI or machine learning or in just-in-time adaptive interventions. Rather, I am an active student of both. And secondly, Glooko does not offer the predictive analytic or JEDI solutions on its platform yet. This presentation is designed to be exclusively educational. So let's define the scope of the problem that we're trying to solve. I'm speaking to a group of experts, so I'll keep this rather short, but this taken from Public Health England tells us that 5 million people in the UK are at high risk of developing type 2 diabetes, and there are currently 3.8 million individuals with type 2 diabetes, and approximately 200,000 new diagnoses each year. Type 2 is, of course, a major cause of premature mortality, with around 22,000 individuals dying every year in England as a result of the disease. Also, from the same website, we can see that there are rising costs to type 2 diabetes. Currently, about 9% of the annual NHS budget is dedicated to the treatment of type 2 diabetes and its complications at about £8.8 billion per year. And this is because of the cost of complications such as blindness, kidney failure, large vascular events like stroke or myocardial infarction, and amputations. It is also notable, and these data come from the UK PDS study, that glycemic control worsens after diagnosis of type 2 diabetes. This occurs both in conventional treatment and with the more recent intensive insulin treatment paradigms. You can see that in the approximately 15 years post-diagnosis, that glycemic control continues to rise to an elevated level and above the target for disease treatment. I also wanted to point out that some of these same principles and concerns apply to type 1 diabetes. Now, I wasn't able to locate data in time for this presentation from the UK specifically, but as a US researcher, I have access to information and knowledge about the T1D Exchange Registry, which was a registry of over 80 diabetes centers performing health outcomes research together in the last decade. And here you can see how glycemic control changes across the lifespan in individuals with type 1 diabetes. A couple of things are notable. The first is that the median glycemic control is above the US target for treatment, which is 7% or below. And secondly, that glycemic control is not only higher among children, but it rises from age 8 to 18 and takes until about age 30 to settle back into what one might consider the adult pattern. So I call this peak on the left-hand side of this curve, Mount Kilimanjaro. This is the insurmountable obstacle that we as pediatricians, remember I'm a pediatric endocrinologist, must try to overcome. It also indicates that much of the lifetime risk for diabetes-related complications in type 1 diabetes occurs among children for those who are diagnosed during childhood. The next thing that I'd like to transition to is how we can improve the state of care for individuals with type 2 and type 1 diabetes, both adult and pediatric, in our clinical centers. And that involves first identifying at-risk individuals. It is important to recognize that we are surrounded by oceans of data in our health systems and in diabetes care in particular. But we only are able to glean from those oceans of data, rivers of information, small puddles of knowledge, and occasionally the odd drop of wisdom. And that is because our decision-making heuristics rely on only a very small pieces of information that we collect at each clinical encounter today. But what if we could use all of the available information in an electronic health record, and as well as the information collected by the person in their daily self-management? Then we might be able to invoke the tools of machine learning, which have transformed so many other industries. Now, it's important that we pause for a moment when I mention the term machine learning, because when you hear that term or you hear the term artificial intelligence, you might be tempted to picture this or this, which would indicate that we have machines or robots doing the work for us. And I'm here to say that that's really not true. Machine learning is really just a fancy form of mathematics that is performing computations that can help us to gain insights. So artificial intelligence per se does not exist in medicine today, but machine learning and deep learning as an offshoot of machine learning both do. Ultimately, it's not a machine that has to take action on the information. It is a clinical expert, a human being who has to take action. And we must remember that. So back to my question, what if we could combine data from the electronic medical record, as well as survey data that we might collect in the due course of business and clinical care, for instance, from our intake forms at the point of clinical care, as well as self-management device data. So data coming from blood glucose meters, continuous glucose monitors, insulin pumps, the newer hybrid closed loop insulin pumps, and the smart insulin pens that are about to make a splash in the marketplace globally. Then we might be able to transform the way we conduct population health. I believe it is true today that globally very few diabetes centers track population health or use risk-based management protocols. And as I asserted in my initial slides, no diabetes center likely uses the ocean of data effectively. So the way I conceptualize this is that if we take any given clinical population, a clinic population has diverse risk for any given outcome of clinical importance to us, and presumably diverse responsiveness to any therapy that we might put in front of them. And if you look to the bottom right on the slide here, you can see the way I've categorized the therapies. So the primary therapies might be drugs or biologics or devices. So it might be the type of insulin you're on or the type of self-management or insulin delivery device you're using. But wrapped around these, we can position behavioral interventions targeted to the individual and care delivery interventions targeted to the clinic or the system of care. And mHealth or digital health applications may help to scale both of these. And we might be able to use all of the available biomarkers to risk stratify the population, as you see here in the middle, into low risk and high risk categories, and then try to target different behavioral care delivery or digital health therapies to that high risk cohort. So the next few slides are going to be used to show you some data from my own research practice with my academic hat on. These data have been presented previously at both the ATTD conference and the American Diabetes Association conference. So the first indicates a model that we have developed for predicting hospital admissions for diabetic ketoacidosis in youth and young adults with type 1 diabetes. But I want to emphasize that this general approach could be applicable to individuals with type 1 or type 2 diabetes, pediatric or adult. So in this particular case, if you'll follow with me, we took a sample of individuals who were diagnosed with type 1 diabetes for at least 3 months. We created a training set and an initial testing set, and we applied, after some consideration of various options, a form of recurrent neural network model, specifically a long short-term memory model. And this model included data that were discrete data from electronic health records, as well as from diabetes self-management devices, as well as natural language processing that helped us to evaluate terms that were used in free text clinical notes. The model evaluated approximately 600 features. And one of the interesting things about a long short-term memory model is, as you can see on the right here, the boxes in the greenish color indicate 90-day periods, and the boxes in the orange color indicate 6-month periods. And for each 90-day period, we take a summary of all the available data, and we can predict whether a hospital admission will occur in the next 180 days. But what the long short-term memory model allows us to do is to consider every historic 90-day period and the summary of discrete features, as well as the prediction that was made at each 90-day interval, and to carry that forward and provide it some weight so that it becomes a feature in the neural network that informs the model. So this model considers not data that is exactly equivalent for every individual. For an individual with a 9-year history of diagnosis, every 90-day period is considered. And for an individual with a 1-year history of diagnosis, the available 90-day periods are considered. So how does a model like this perform? This is a deceptively simple table, but I'll walk you through it. What we did is we created a rank ordered list by probability of hospital admission for all of our patients in our diabetes center. And we selected from that list of 2,400 patients in our clinical practice, a list of 80 individuals who had the top risk for admission. Now, we then stratified that list of 80 individuals so that we could separately evaluate the top 5, the top 10, all the way to the top 80. And we evaluated some performance metrics of the model, including the precision, which is equivalent to the positive predictive value, and the recall, which is equivalent to the sensitivity. I want you to remember that 80 individuals were selected for this list because that's approximately the number of individuals who are admitted to the hospital in my practice every 6 months. Now you can see that at the top of this list, the precision is approaching 100%. It drops to approximately 56% partway through the list, and to 33% if we were to consider taking action on all 80 individuals on this list. And when we evaluate or consider all 80 individuals on the list, the sensitivity is that we can make a precise prediction on 33% of the population of 80 who will be admitted. So these metrics deserve just a little bit of attention, because even at the 80th position in the rank ordered list with a precision of 33%, keep in mind that against a backdrop of 5% of individuals being admitted, that is a risk-based enrichment of over sixfold. At 56%, you can see that it's a risk-based enrichment of well over tenfold. So we are moving the needle here on our ability to rank order by probability of hospital admission. I'll show you briefly another model that we've created. So in this model, we are predicting future rise in hemoglobin A1C in the next 90 days among youth and young adults with type 1 diabetes. Again, I am providing you examples from my own research, but the principles should apply to adults with type 2 and type 1 diabetes as well. So in this particular case, as well as in the risk prediction model for hospital admission, one wants to start thinking about how to intervene. And the way we have selected to intervene in this particular population selected by this model is that we are inviting individuals to participate in a remote patient monitoring intervention where they receive a weekly or biweekly video chat or phone call. And in some cases, we may invite them into another intervention layered on top of that, such as a peer mentoring program or a digital therapeutic of some sort or other. So how does this model run and how is it performing? Well, in this model, we selected a cohort of 9 to 18-year-olds who were diagnosed for greater than 6 months. You can see that we evaluated close to 10,000 clinical visit intervals every 3 to 5 months. And we selected a random forest model. So this is just a series of many decision trees. It's a statistical approach to the machine learning. And we included both discrete data and natural language processing derived features from free text clinical notes. And this model evaluated approximately 300 features after a threefold validation. And here you can see that the positive predictive value is approximately 56%. I will tell you, although I don't show it today, that we are approaching 65 to 70% positive predictive value after we added self-management device data. And that is against a backdrop of approximately 30% of individuals having a clinically significant rise in A1C, which we defined as a rise of 0.3% using the US units or greater in any 90-day period. So the question next is, what do you do about it? Well, what you do about it is you think about how to get the care out of clinic. And this is a significant effort. Remember that our patients, whether type 1 or type 2, spend only 0.03% of their waking hours in clinic with us at most. And the rest of the time, they're on their own. So years ago, I conceptualized this approach to diabetes care that I jotted down on the back of a napkin. And here you can see my slide-based rendering of it, that an individual could share their data to a cloud via a mobile app or a direct cellular connection. that the diabetes center could aggregate the data from multiple external cloud sources, bring the data down into data visualization, web dashboard, create alerts from those data to alert the diabetes care team to clinically significant events. And then the diabetes care team might interact with the patient via digital tools such as text messaging or video micro visits. And in North America, in the US in particular, we now have billable codes in our fee-for-service model that are actually supporting this mechanism of care. But it's still very early stages to understand how it's working across diabetes and other chronic diseases. So this is how I think we can achieve a smart, scalable approach to diabetes population management. The first is to create population health dashboards at each clinical center, to incorporate prediction rather than just Boolean searches of the medical record, so that we're not risk stratifying patients based on what has already happened, right? Individuals who already have an elevated A1C or some complication of diabetes, but that we are forecasting and getting in front of clinically important problems. Then next, we implement some form of remote engagement or remote healthcare delivery in our clinics. And finally, we layer on top of that some digital therapeutic approach that allows us to scale the behavioral nudging really rapidly. And in its best form, I think, leverages just-in-time adaptive intervention techniques, which I will talk about in just a bit. And one uses quality improvement methodologies to drive this in clinic so that in near real time, one can see whether you are moving the needle on the problem that you seek to solve or on the outcome that you seek to improve. It's important to keep in mind that quality improvement is hard work. In my own academic practice, we use the model for improvement and the Deming wheel. The Deming wheel includes plan, do, check, act cycles. You can see here I've called it plan, do, study, act cycles. And one begins by asking the question, what are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in an improvement? And then one uses hunches, theories, and ideas to rank order a list of change ideas that come from an environmental scan and evaluation by an expert group that may include patients themselves, individuals with diabetes themselves, so that you can rank order ideas for change by potential impact and by the effort in your clinical center at this particular moment in time. And then one takes those items that are likely to have the greatest impact according to the experts in the room and that are likely to be the least effort to implement today, and those are the ones you start with. One also uses all of the other tools of the trade in quality improvement, including a key driver diagram to guide the selection of intervention strategies. So the change ideas that I just mentioned should come from some knowledge of the primary and secondary drivers of the outcome you're trying to move the needle on. So for instance, if I wanted to improve the proportion of individuals with an A1C that is in target by 10% in the next 6 months without an increase in low blood glucose events, I might acknowledge that the pillars of diabetes self-management indicate that glucose monitoring, taking medications appropriately, being physically active, and eating healthy are important proximal drivers of that outcome. And then I might evaluate for secondary drivers that will help the individual to engage in those particular behaviors. So for instance, the individual's perceived benefit of glucose monitoring, reduction of barriers like access to test strips or CGM sensors, and knowledge about the potential benefits of that aspect of therapy might be important drivers. And then I would map various intervention ideas to those. Okay, so that's a lot, but I'm going to shift gears for a moment, and I'm now going to talk about how one identifies optimal moments and approaches for nudging behavior. So you'll note that we're shifting from driving improvement at a population level and a system level to driving improvement at an individual level. And I'll just share a few high-level thoughts about this today. So first, I'd like to define what a just-in-time adaptive intervention is, or a JEDI. A JEDI is an adaptive intervention design concept aiming to provide just the right amount of support at just the right time to the right individual based on an individual's changing internal and external states. And you can see the reference from which I draw this down below. So there are a number of investigators who've done some very deep scientific work on this. Dr. Nahum Shani is one of those. And you can see an article here that sort of defines in a little more detail what a JEDI is. And I have taken the liberty of including this diagram from that article. And you can see that JEDI might look a little bit similar to the key driver diagram I just showed you, except that it is tailored to an individual rather than a health system. So in this case, one has a distal outcome. This is analogous to the SMART aim we talked about earlier, that one is trying to move the needle on. Proximal outcomes, so these might be primary or secondary drivers, like improving blood glucose monitoring, which might improve hemoglobin A1C or time in range from a continuous glucose monitor. And then one has tailoring variables and intervention options. And these might be analogous to those change ideas that we were talking about before. But something that is new here are the decision rules and decision points that help you to scale which intervention option to deliver at which moment in time in a momentary way with the individual. So I'm going to show you a brief example of a JEDI. This comes from research published by Evan Foreman and colleagues, and this was called On Track, which was a JEDI incorporated into a smartphone app designed to predict and prevent dietary lapses. And you can see a diagram here, so I'll just walk you through this diagram. So in number one, you see the intervention component, which is the actual activity selection that one engages in. So this is the overall structure of the JEDI, if you will. In number two, you see the actual intervention options. So there were three options in this particular application. One was an active walking suggestion. The other was a lighter anti-sedentary suggestion. So rather than doing some moderate physical activity, just to get up and take a few steps, take a break from sitting. And the third was no suggestion at all. You can see that the distal outcome in number three was the total steps taken across the study. And the proximal outcome was the number of steps in the 30 minutes after a particular text message or push notification suggestion was made. Number five indicates the decision points across the day. So they had 5 different times a day. For instance, in the morning before the daily commute, and in the evening before or after dinner, I don't recall the details exactly, would be decision points. Number 6 includes observations of context. So, what was the individual's location? What was the weather? What day of the week was it? What was the individual's primary step count for the prior day? How much variation has there been in the prior 30 minutes? What was the user-rated usefulness of previous prompts, et cetera, et cetera. So these observations of context, I will note, give us the first opportunity for machine learning, which is to identify the right moment using a reinforcement learning approach in which to nudge an individual into a behavior that promotes health. Number 7 incorporates some user responses that indicate their availability to act on the suggestion. And then finally, number 8 includes some randomization probabilities. So this is where A/B testing using reinforcement learning at a second point in a JEDI. So reinforcement learning to A/B or ABC test, as is the case here, different strategies for nudging behavior comes in. So how do we put this together? How do we create new just-in-time adaptive interventions to drive outcomes? Well, One has to recognize that if you want to scale this in the form of a mobile application, one has to think about health strategies that can be delivered via a text message or push notification in some way. And one has to recognize that these should be theory informed. So I've shown you just a few health theories here: the health beliefs model, the theory of planned behavior, stages of change, or what's called the trans-theoretical model, social learning theory, diffusion of innovation theory. And whatever the model is that one chooses, it's important to recognize that there is some rationale by which you believe that this particular strategy for nudging behavior will work. So, how do we identify strategies for health behavior change? What are the moments of opportunity, if you will, or the behavioral targets, those proximal drivers we can try to act upon? I give to you, the pillars of diabetes self-management as defined by the ACDES organization, formerly the AADE, the Organization of Diabetes Educators and Education Specialists and self-management specialists in the US. So these include healthy eating, being physically active, monitoring the disease appropriately, taking insulin and other medications, problem solving, healthy coping, and reducing risk and risk-taking behaviors. And then the second thing to take note of is what are the data that we might use to inform and customize a JEDI. So I've got a laundry list here. This is by no means an exhaustive list, but I've selected data that might come from an electronic health record, that might come from a mobile application like Glooko or similar applications, and that might come from fitness wearables that could feed into a mobile application on the user's mobile phone. I would note that data coming from electronic health records like demographic and other clinical care data in the lower right, you can see may allow one to segment the population so that you can customize JEDI to different segments of the population, which may be a very useful feature. So what are the steps to building a JEDI? Well, the first is to capture sensor data from wearables and smart devices, from patient-reported outcomes and patient-reported experience surveys, so you can monitor the user's state. The second is to evaluate. So one can use initially a rules-based algorithm to get started and eventually evolve to a machine learning-based model that allows one to classify or predict moments of vulnerability or opportunity for engagement, and to A/B or ABC test different behavioral intervention strategies from the behavior change wheel. And then finally, is the alerting approach, the third step in the three-step process, which is to message users at moments that matter, using the moments of opportunity and variability to deliver just the right interventional strategy at the right time for the right user, which I will refer to as precision engagement, which I think is an evolution from the field's thinking about precision medicine. We also need precision engagement because 90% of chronic disease management is actually behavioral rather than physiologic. So here's an example of how to put it together. So one could detect data, for instance, related to physical activity. One could identify that the individual might bicycle on the way to work, and the outcome you want to drive might be to change blood glucose levels over a 2-week period. And then one might send a push notification that would help nudge the individual at the right time of day to choose to bike to work rather than to take a train or a vehicle of some kind. One can refine the intervention, so one can have the user rate the advice that they get in real time so that you understand which strategies are working or not working. One could, of course, also just examine the user's behavior if you have sensors, like a smart fitness wearable, to let you know whether the user responded positively or not. And the user could leave positive or negative feedback that can help you refine the interventional strategies or the messaging strategies. One can also identify the proper timing. One can examine how to avoid unduly pressuring the individual. One wants to send tailored actionable alerts without putting pressure on the user so they don't disengage. And one wants to personalize this, so allow the user the chance to opt out of action-oriented notifications. Other best practices include helping the user to link cause and effect. So the user should think about the link between certain actions and the proximal outcomes of those actions. And one should align with the user's perception of the utility or benefit of the messages. They should be consistent with the user's perception that they will benefit from taking this action. Next, one wants to individualize, tailor to the individual. One should recognize that no matter the strategy, one function of all these messaging strategies is to draw the user's attention back to their disease self-management. So there's a reminder function. Nudging should be practical. So there should be some actionable advice provided so that the user can step into action. And then, of course, there must be a visible payoff. So the user must, again, perceive that there is value to investing their time in this. Next, there should be a precision to the messages, so they should relate to the user's actual experience. Otherwise, they may not trust the nudging that they're receiving. It should link to their motivation, internal or external. In some cases, one can use motivational interviewing techniques in a text messaging intervention. And in some cases, one might consider a behavioral incentive from behavioral economic theory. So, one can use positive messages over negative messages. One can even consider JIDIs that include a financial or non-financial incentive of some kind. For instance, unlocking a compelling video congratulating one on their success. And then, putting it all together, the holy grail would be to evolve beyond just rules-based algorithms for doing this to creating a continuously learning nudging system that tailors to the individual's characteristics through the use of A/B testing and remote and reinforcement learning. The goal would be to continually increase the satisfaction rate and the efficacy of the messages. Messages should aim at creating positive reinforcement, as I mentioned earlier. So one wants to avoid blame, one wants to include some form of reward or perception of value to the user. And this should link to the notion of the proximal drivers or the engagement behaviors that we know drive the outcome that we're seeking to improve. And one should ensure that management procedures achieve privacy goals, ethical goals, and accuracy at each stage, from data collection to data transfer to processing and analyzing the data. This is crucial to the user's trust in the system and their satisfaction rate. Note that one requisite item for achieving a functional JIDI is breaking down the silos of data. So one must be able to integrate data from multiple sources. So that's it for today. Those are my thoughts, on how to drive improvement in diabetes self-management, both at a population level or a system level in a clinic and with an individual in a scalable way that incorporates forecasting or predictive analytics. Matt, I'm going to hand it back to you, and thanks so much.
Thank you, Dr. Clements, for an excellent presentation. That really was great. And as we'd love to hear from you, the audience, with any questions that you may have regarding today's symposium session, we ask that you send these directly to our speaker, Dr. Clements, using his details on the screen. And for any Glooko-related questions, like upgrading to Glooko from DIASEN, for example, please send these directly to our support team using the details again shown on the screen. Now, with that said, we would like to thank you all for joining us this evening. We hope you enjoyed the sponsored Glooko online symposium session, and have a great evening and a fantastic weekend. Goodbye.